Going to hit the record button and we will get started. So again, thank you all for being here tonight. This is the sixth episode, if you will, of Topics in Trauma Nursing. I try to do these about every couple of months, about 4 times a year, quarterly, I guess that would be, and bringing topics of interest to like-minded individuals who have a passion for trauma nursing and emergency nursing in general. And tonight is no exception to the rule. And it's wonderful to see a great outpouring of participants tonight. I think this is probably the largest number of participants we've had for one of these sessions since I started a little over a year ago. So it's really great to see everybody here tonight. So what is Topics? I've kind of given you a little bit about it, but will kind of be official for anyone who's watching this on YouTube. It's a quarterly educational offering designed to bring cutting-edge topics in trauma care to emergency and trauma nurses. Initially, this is for New Jersey, but I've actually got some people that have picked up on YouTube and are joining us that are outside New Jersey. We've got people who have joined us from California and Florida, or will go on YouTube and evaluate, send me comments that are outside the New Jersey area, but hey, look, I'm a New Jersey-based clinician. I think almost everyone on this call is as well. So we'll keep it kind of Jersey proud tonight. The goal tonight is really pretty simple. Just sit back, enjoy, absolutely ask questions, recruit more nurses for the next session. And I'll give you more information on that shortly. As I mentioned earlier, all of our sessions are recorded. They are available on my YouTube channel, The Trauma Geek. Yes, I branded myself. My daughter is just kind of rolling her eyes in the background here. But that QR code that is down at the bottom of this page will give you a direct link into the YouTube page. And even if you don't have a QR code reader available, just go on YouTube and just search The Trauma Geek and you will pull up the page. And right now, I think there's about I want to say a dozen, maybe a little less than a dozen different topics that are up there. Some of them are topics in trauma nursing. Some of them are from a companion talk that I do called the Trauma Nursing Journal Club. And there's a couple of other little videos that are up there that are, again, typically almost all are trauma related because that's kind of what I am in life. You might want to set your calendar for the next Topics in Trauma session. It's going to be December 13th, so just a little before Christmas. It'll be our Christmas episode. And for that, we're going to be talking about ballistic basics, understanding the injury potential of gunshot wounds. So if you have an interest in learning a little bit more about ballistics and what they mean, and you kind of want to join in for that, then certainly make note of this particular date. Again, snap the QR code. And once again, for those of you completing evaluations, I will send you not only a link to the YouTube video, but I'll also send you a QR to sign up for this next session on December 13th. All right, so like I said earlier, make sure your microphones are on mute. I can certainly do that from my angle, but like I said, I'm very bad at multitasking, so just ask you to kindly do that. But if you do want to ask a question, pull yourself off mute and ask a question at any time, or you can save your questions till the end. That's perfectly fine as well. I would tell you to put them in the chat box, but I'll never see them. So just hold your question and try to ask it toward the end. And again, we will have an open forum at the end, and I'd like to have a little bit of live discussion. Maybe we can come up, we can put our cameras on and kind of do a little bit of a quick roundabout chat on any questions you might have about anything we talk about tonight. There is continuing education available for this, so you will get 1 contact hour for completing the evaluation at the conclusion of tonight's program. Once again, if you have the ability, I would recommend that you pop out your phone and I will provide you with a QR code. Also, I will try, it's going to be a multitask, but I'll do this toward the end. I'll try to put a link in the chat box that you can click on the link from the chat box as well. And if I forget later on before I sign off, just somebody remind me verbally, and I'll make that happen for you if you don't have the ability to scan a QR code tonight. I do want to extend a welcome to some nursing students that are attending tonight's session from William Patterson University. Thank you all for being here. I appreciate it. Part of their curriculum is they have to attend a similar meeting to what we're holding here tonight. So we are thrilled to have some future colleagues joining us tonight. And my goal for them is that we'll make you trauma nurses, emergency nurses after tonight, and you'll have a passion for when you graduate going right to the emergency department. Yes, you can do that. Yes, you can be very successful doing that. I'm a testimony of that. I was a new grad in the emergency department, started my first day after graduation as an emergency nurse, and have never looked back after 37 years. All right, let's talk about what tonight is going to be all about. So tonight I'm actually doing a representation of a talk that I gave at the annual New Jersey Emergency Nurses Association's Emergency Care Conference back in March in Atlantic City. And I'm going to be talking about the shock index, and particularly why this is, and it's not even so much it's an emerging tool anymore, why this is really a valuable tool for those of us that are working in the emergency and trauma setting when it comes to assessing our patients, our trauma patients, for severity of trauma. This is a very timely topic because the shock index, as we'll find out as we talk through the slides over the next 25 minutes or so, it's not a new concept, but it's a concept that's just for whatever reason kind of come full circle back around now and is slowly but surely being integrated into a lot of facets of trauma care. So for those of you that don't know me, my name is Steve Weinman, and I am with the trauma program at St. Joseph's University Medical Center in Paterson, New Jersey, part of a wonderful group of trauma clinicians that practice up in the northern part of New Jersey. And my comments here tonight are those of my own. They are not a reflection or an opinion of any of the agencies or organizations or employers that actually call me an employee. So these are just my opinions based on my review of the literature and my clinical experiences, both in the pre-hospital setting, where I volunteer as a pre-hospital nurse / EMT, and my hospital-based practice over many, many years. Have nothing to disclose, although I wish I did. All right, it's all about trauma. And what is trauma? It's wrong place at the wrong time, right? And that's really kind of an acumen that we see for a lot of the patients that come across our stretchers in the emergency department. Whether you work at a trauma center or not, we know that trauma is a happenstance event, and it is a very preventable event. But as preventable as it may be, sometimes we can't always prevent things from happening, right? So that being the case, for those of us that are clinicians, we need to have a good eye on what we need to do to adequately assess and then intervene for our patients when they come in after suffering a traumatic injury. Now, I throw the reference list up here first because I think it's really important. This is an extremely important topic. It's a very passionate topic that I have. I'm kind of on a one-man wrecking crew to get the concept of the shock index out there, both in the hospital-based setting as well as the pre-hospital setting for our pre-hospital clinician colleagues. So this is just a quick snippet of the references, with two in particular that are highlighted that I really highly recommend that if you do find tonight's talk interesting, that you follow up and look at both of these articles in particular. I'd recommend you read all of the articles, but I'd be happy if you at least read two of them. One of them is by Kierbach. It's Pre-Hospital Shock Index Outperforms Hypotension Alone in Predicting Significant Injuries in Trauma Patients. This was published a little bit over a year and a half ago, I believe it was, in Trauma Surgery and Acute Care Open. This is an open access journal by the British Medical Journal that you can find online, and all you have to do is just Google Trauma Surgery and Acute Care Open, and you will pull up the website and you can find this article pretty easily. And the other one is by Koch et al., The Shock Index in the Emergency Department, Utilization and Limitations. And again, this is another open access article, so you don't have to either be institutionally affiliated or have to pay for a reprint of any of these articles. And there's a variety of other articles in here as well that I would wholeheartedly recommend that if you do have a bit of an interest in this after you hear about it tonight, or already have an interest in it, which is why you're tuning in tonight, that you spend a little bit of extra time exploring the literature. All right. So, just by a show of hands, and if you want to bring yourself on the camera for just a second for this, that would be great. But just through a quick show of hands or a thumbs up on your screen, how many of you have heard of the shock index prior to tonight? Anyone? Anyone? Bueller? Bueller? A thumbs up if you haven't. Raise your hand if you have, just as a curiosity. I've got about 25 or 26 people on tonight, and we'll just kind of take a look here. All right. So really the majority, the vast majority have not. Okay. So good. It's a good thing that you're here. I'm also glad that you didn't like see tonight and go out and then become an expert before tonight to challenge me on this. So let's talk a little bit about it. So, and you're not alone. This is something that I find as often as I talk about the shock index, and I figure out a way to get the shock index on almost every conversation about trauma that I have. It's very commonplace for clinicians across the spectrum, from EMTs in the pre-hospital setting to trauma surgeons in the trauma bay, that they haven't heard of the shock index. So it's a good thing you're here tonight. I hope that I will kind of bring you over to the shock index side of life. So again, most of you really have not, so I'm not going to have anybody come on and answer the question about how you're using it in your practice. For the one or two of you that did raise your hands, if you've heard of it, you're probably using it in some fashion in your practice. And hopefully after tonight, one of the pearls of tonight will be learn it tonight and use it tomorrow. So maybe hopefully tomorrow you'll be using the shock index as you go back to the emergency department. So what is it? That's the big question. Simply, what is the shock index? Well, guess what? We're all in medicine, which means nothing that we do is rocket science, right? And the shock index is not rocket science either. Simply put, the shock index is the heart rate divided by the systolic blood pressure in your trauma patients, okay? The significance of this is really that in adults, a shock index of 1 or greater is considered clinically significant for the possibility of severe underlying injury. Okay, pretty simple. It doesn't really get much more complex than that. We're going to look a little bit at the literature tonight because I want you to understand that this is not just something that somebody kind of pulled out of their butt. This is something that's got a good base of evidence now to support it. But at the end of the day, the shock index in the adult population, and we're going to talk in a second about the pediatric population because it's utilized in that population, but because of pediatrics, and for those of us that are pediatric experts out there, we know nothing is straightforward in that pediatric population. It's all based on age and weight and all of that stuff, right? So anyway, heart rate divided by systolic blood pressure. If it's 1 or greater, which means if the heart rate is equal to or greater than the systolic blood pressure, then you're going to have a high shock index. In peds, there's very similar. The shock index there is a little bit more cavitated depending on the age of the child. So it's not just like in an adult, age about 15 and over, that it's 1 and above, and that's the number. With children, it gradiates up and down a little bit depending on their age, because we know that their vital signs, their baseline vital signs are very different as you go from being preschool, toddler to preschool to adolescence. It's a little less understood as to how the shock index fits in on pediatric patients, but I'm going to present an article that's quasi hot off the press and a little bit that really I think has done a good job of really kind of putting this to rest. And if you, again, want to put this into your vernacular of, items that you post or things that you keep in your mind, if you deal with pediatric trauma a lot, then certainly I think the applicability of using the pediatric trauma index is certainly ready for prime time. All right, so if you haven't heard of it, and again, by a show of hands and thumbs earlier, I'd say probably 90% of you listening tonight have not heard of the shock index, and you're not alone. And this, again, goes from the pre-hospital setting all the way up to definitive care in the trauma bay and beyond. So why have so many of us not heard of this very, very simple construct? Well, because baseline education and continuing education, particularly those of us that go on to take the certification classes that are out there, don't mention it. If you've ever taken an ATLS course, predominantly a physician-based course, but a lot of nurses will take it, it mentions it once in the entire book, once. And it only mentions it in passing, all right? Doesn't talk about integration and what it means. TNCC, negative, does not mention it. None of the slides mention it. Just got done teaching TNCC yesterday and today at my institution, an eye on the shock lecture and looking at the book. It's not mentioned, okay? And if you're a pre-hospital clinician, same thing with pre-hospital trauma life support. There's no mention of it in the book or the slides for that either. And I teach in all three of these courses, and I can certainly tell you it makes me nuts, because any opportunity I have to talk about the shock index, I talk about it, okay? And here's something that's sad. Right now, TNCC is about to come out, or has come out with the 9th edition. So it's actually going to launch later this fall, early next year. And guess what? It's not mentioned in there once again. And I'm a little pissed off about that. And then, especially since I chair the ENA's National Trauma Committee, I'm a little mad that some of the comments that I've made over the past year did not matriculate into TNCC. But I'll just continue on my tread of bringing it up every chance I get during a TNCC course. And PHTLS is the same thing. It's about to go to its 10th edition, I believe. And once again, there is no mention of the shock index in there. So it's a little bit disappointing, but not surprising, unfortunately. So what ultimately got my attention? So I was preparing and scanning the literature for some articles for a companion talk that I do called the Trauma Nursing Journal Club. And I came across this particular article that was published, as I mentioned earlier, in Trauma Surgery and Acute Care Open. It's an open access journal put out by the British Medical Journal. And this caught my eye. And I'm like, what is this pre-hospital shock index? And how does it outperform hypotension, which is the gold standard, right? We take a look at our patients, and if they got a blood pressure in an adult, not a geriatric patient, but an adult or an age appropriate child, less than 70, less than 90, then they're hypotensive. Ring the bells, get the MTP going, right? And certainly we know in the elderly population, we look at that systolic blood pressure being less than 110 for that hypotension. But what caught my idea, because I've always kind of felt in the back of my mind, is hypotension alone a good indicator of whether or not somebody's in shock or not? And, for those of you that have been out there and been an emergency nurse for any more than a day, how many patients do you have that come in that maybe stubbed their toe, or maybe were in a car crash that had a blood pressure of 90 when they came in? And that's really because that was their blood pressure. Okay. So the reality is that hypotension is in the eye of the beholder, and it's one variable. And you're going to find some interesting information as I go tonight about where we even came up with the construct of 90 or 80 or whatever those two numbers you want to use, or 110 being a litmus test for hypotension and severity of injury. And guess what? It's not. Spoiler alert. So I came across this article, and I'm going to come back to this article because it really served as a basis for how I really kind of put together some this talk in particular, but also what really kind of turned my attention and made me a convert to using the shock index in my trauma patients. And I'll tell you now, when I get on scene in the ambulance and I get a set of vital signs, or when EMS is calling a patient in, or when I hear the vital signs on any trauma patient, the first thing that I think about is, what is their systolic blood pressure, what is their heart rate, and what is their shock index? It's just automatic at this point in time for me. All right, so where do we find talk about the shock index? All right, obviously it's out there in the literature. If you do a lit search, it's out there, and I'll show you kind of my results of a lit search that I did just the other day. But one of the problems was it wasn't in the old trauma triage guidelines that were put out by the CDC about a decade ago. And the trauma triage guidelines, if you're not familiar with them, if you're not either trauma center bound or you are trauma center bound and you don't know what they are, which you should, they really are those initial trauma triage steps that are used at the pre-hospital level to determine patients in the field as to whether or not they need to be routed to a trauma center based on some defined criteria. And it also, for trauma centers, allows us to kind of formulate how we activate our trauma team and what kind of resources we need based on physiologic indicators, mechanism of injury, age of patients, things like that. This is the algorithm that used to be, and I say used to because this has changed fortunately recently, of what used to be the old trauma triage guidelines, the field trauma triage guidelines, as put out by the Centers for Disease Control. Okay. And, problem was that there were a number of main parameters we looked at. We looked at things like physiology, anatomy, and we looked at mechanism of injury. And it was a very algorithmic approach. If this, then this. If not this, then this. And At no step in here did we find anything about a heart rate being an indicator of how we triage a trauma patient. We looked in, particularly if you look here at the top, and I'll blow this up for you, we have a systolic blood pressure of less than 90. Whoop. What does that really tell us? I don't know. I mean, you really have to ask yourself, did that really tell us anything? But there is no mention of a heart rate. And you know what? You think about it, why is there no mention of a heart rate? I mean, I think all of us, when we get vital signs on our patients, whether they're traumas or not, we look at a heart rate. It's considered the fabled major classic 4 vital signs, but it's not being used, or it was not being used as an indicator on severity of injury. And that, I think, was a very major faux pas. So NION, in the end of 2021, published in March of 2022, the American College of Surgeons took over trauma triage guideline development, which I think is very, very good. The Committee on Trauma said, hey, this is really in our lane. Why don't we work on this? And why don't we try to simplify the approach so that our pre-hospital colleagues will be it'll be a little easier for them to determine whether or not a patient needs to be routed to a trauma center or not. And it also will give a little bit more evidence-based guideline for trauma centers on how to activate their trauma teams and when to activate their trauma teams. So in this particular set of guidelines, we went away from that algorithmic approach to a red box, yellow box approach with some very defined characteristics. But what was so cool and what caught my attention, and of course, this is almost exactly coinciding with my finding the article and doing the Trauma Journal Club on shock index, was this: heart rate greater than systolic blood pressure as an indicator for trauma triage. Holy shit, that's the shock index. Boom, it's there. It's now ready for prime time. The QR code that is displayed in the lower corner will give you the link that'll take you to the American College of Surgeons site, where you can find everything you ever wanted to know about these national triage guidelines, but were afraid to ask. So if you have never heard of them, particularly if you work in a trauma center or you're a pre-hospital clinician in addition to being a nurse, then I wholeheartedly recommend you spend a little time going over this website and understanding these new trauma triage criteria. But from my standpoint, and from the standpoint of tonight's talk, holy cow, we finally have some validation in national guidelines as to the shock index and when it should be used. It blew my mind, and I was like a pig in mud when I saw this. And really, it needed to be there. It was about time. So as I started to kind of do a little bit of research and put a talk together for ENA, I went back and looked and thought, when did the shock index even come into vogue? When was it first mentioned in the literature? And I'm like, holy shit, 1967. 1967, in the German Medical Journal, which is written in German, they mentioned the shock index. And they, at that time, it was in ICU patients using arterial blood pressures, and typically arterial pressures, systolic, and pulse rates. So it was out there. So 1967, I would venture to say that the vast majority of the people on this call tonight were not even born when the shock index was first introduced. That's how long it's been out there, okay? So that being said, flash forward now to this week in PubMed. If you do a search of literary sources of the shock index, you will find on PubMed there are 15,341 references. This is as of September 2nd, all right? And if you do a Google search for shock index, you will pull up almost 400 million citations. What? Yeah, that's a lot of stuff. So the reality is that somebody knows about the shock index, but horrors of horrors, why did the vast majority of you on this call tonight not hear about it? Again, it goes back to the fact that we've got this pretty decent indicator that we are just not talking enough about in our clinical setting. Hence, Steve's one-man drive to get the shock index known to everyone out there who touches a patient who's injured. And guess what? Shock index isn't just new to trauma, all right? I'm talking about it in trauma. I'm the trauma geek, so I'm all about trauma. But guess what? There's articles out there about its use in postpartum hemorrhage. Makes sense, right? Ectopic pregnancy. Makes sense. MI, stroke, PE, sepsis. Makes sense. GI bleed. Makes sense. And then those pediatric applications. So guess what? This is not just a one-horse town. This really is something that's out there and has some good literary sources across the spectrum. But again, we're talking about it in the trauma patient tonight. There are also, as you can imagine, because this has been around for over 50 years now, there's also variations of the shock index that are out there. What we're talking about tonight is the straight shock index, the traditional heart rate divided by the systolic blood pressure. All right. That's what the most of the literature is on, and that's what I hang my hat on. But there are a couple of other things that are out there that have a growing body of evidence in support of, not quite as well as the standard shock index, with regards to how they can be utilized. So in addition to the shock index, there's what's called the modified shock index, or the MSI. And what they typically do is they substitute mean arterial pressure for systolic blood pressure. So this is really, again, in hospital-based clinicians, if you put a patient on a monitor and you can bring up an MAP, or if you're pre-hospital and you're advanced life support and you have a monitor that can bring up an MAP, critical care, you bring up an MAP or they're on an ART line, then you can utilize it. Not as handily utilized as just looking at the systolic blood pressure. All right. There's what's called the age-adjusted shock index, and for that, it's the age times the heart rate divided by the systolic blood pressure. What they have found, and there's a couple of good studies that are out there on this, is that it does a good job on, and based on age, of doing some predictive value of injury. It really is good for predicting whether or not a patient with a high shock index will need to be admitted to critical care. And it does have good predictability in the elderly, because we know comorbidities and polypharmacy in the elderly can certainly predispose them to aberrations in vital signs, particularly their heart rate, and can screw up something like the simple shock index. So this is certainly something that might be ready for prime time eventually for applicability to our elderly population. And then there is the shock index pediatric adjusted, or the SIPA. And the SIPA really, again, looks at heart rate divided by systolic blood pressure, but divides it up amongst the ages and what normal baseline vital signs are for those ages. So again, it's out there. There's a variety of incarnations of them. I'm pushing really just basic understanding here tonight, and that's just the basic shock index. And then published in the Journal of Trauma. This actually came out literally the week that I was presenting in Atlantic City for emergency nurses. This came out, it really showed, again, another incarnation of the shock index as it's related to the pediatric patient. And this was the reverse shock index. It's multiplied by the patient's Glasgow Coma score. Have not spent a lot of time really investigating this. I love trauma, but I don't do a lot in pediatrics. I know enough to kind of like get myself in trouble, and that's about it. But what I can certainly tell you with that is that this could be an up and coming thing that could actually help to actually kind of not have this sliding scale thing and be able to come up with a straight out value that we can use in our pediatric patients. In this particular paper, which was a pretty decently done study, it showed I can say it, statistically significant increases when the score was high, and predicted things like need for intubation, need for intracranial pressure monitoring, particularly in the head injured child, need for blood transfusion, needs for operative intervention, and then ultimately need for critical care admit. So a lot of what we are seeing that's been validated in the adult population using the standard shock index has been applicable, or has at least been in one study with probably a level 3 evidence, which means it's okay evidence, but don't hang your hat on it. Shows that this particular adjusted shock index might be a good thing to use in the pediatric population. Again, the reference is down there. I do not know if this is currently a free article or not. I do have this available. So if you are so inclined to want to have a copy of this article, just send me a quick email, and I'll be happy to send you a free copy of the article. All right. So why? And I've kind of already answered this, but not really. Why is the gold standard no longer applicable? And the gold standard was what? Systolic of 90. All right. And why is it no longer applicable? Why don't we hang our hat? And why should we probably have never hung our hat on it? Well, number one, the number was pretty arbitrarily selected. 90 millimeters of mercury pressure is what is believed to be the pressure needed to keep end organs perfused. The brain, the heart, the liver, the kidneys, blah, blah, blah. All right. Guess what? There's been no good research that's ever done to support this. All right. It's almost like saying that everyone should be walking around with a blood glucose of 80. We know that that's just not going to happen, right? Everybody's going to vary a little bit. And even in our hypoglycemic patients, we have hypoglycemic patients that at 70, they're symptomatic, and we have them at 20, they're not symptomatic or they're minorly symptomatic. So, can we ever say one number fits all? And we try to do that and are still doing it with a systolic blood pressure of 90. There's no solid evidence to support this number. Okay. It's just plain and simple. All right. It is still part of the trauma triage guidelines. If you look above the shock index added, there still is systolic blood pressure less than 90. And you know what? I just think it's because they just could not get it out of their head. It's been around so long, they weren't really to trash the number yet, which I think they really need to do. We also know, again, a lot of people walk around with blood pressures that are somewhere around the 90 mark. And you know what? Does that make them all, if they're injured, candidates for mass transfusion? Absolutely not. We also know that a lot of times we will find one blip in a blood pressure will put people into this shock, run around, hair on fire thing. Patient comes in and they had a field pressure of 90. They get in and it's like 140 over 60. It's like, what? Huh? No, yeah, we know in monitoring people that there are aberrations and there are blips in blood pressure. Somebody can have a vasovagal response, in the pre-hospital setting or even in our department, and they can drop their pressure temporarily, only to come back up, and there's probably nothing going on with them other than this physiologic blip. All right, so that's another thing we need to consider. Here's the other thing, and I think we're all going to smile when we look at this because we've seen this happen. How do we obtain the blood pressure? All right, auto cuffs. Honest, I know they're out there. I know we use them. I know we need to use them because we can't always be taking manual blood pressures on every one of our patients, but they are almost the work of the devil because auto cuffs really aren't the best things in the world. And sometimes they're not giving us the best readings, okay? Especially if they're not calibrated in the back of an ambulance. If we have them, they're jostled around a lot. How, even though they're biomed tested every once in a while, how accurate really are they? Even a manual cuff. How many of us change the cuffs for big arms, for little arms, right? Or we just use the standard adult cuff for everybody, right? And how about clinician variability? We all have worked with that person who every blood pressure is 120 over 80, right? Right? Yeah. Heart rate 80, blood pressure 120 over 80. Every patient. Audit their charts for the last month, and every blood pressure was 120 over 80, right? So again, a lot of stuff out there that really is like saying, maybe we shouldn't just be looking at this. And you know what? At the end of the day, and this is what got me the most, is that we gave absolutely no consideration whatsoever to the heart rate. In none of our trauma triage parameters is there a heart rate listed as an indicator. What? Literally, right? That's just absolutely ridiculous. Because I'm telling you, even before I knew about the shock index, when I looked at the vital signs, I was looking at the heart rate. If I had a trauma patient that came in and their heart rate was greater than 120, wow, what's going on with you? Yeah. There's the adrenaline rush, there's the anxiety, but guess what? A heart rate greater than 120 sustained? Nada. There's something else going on there that we need to at least investigate, right? The shock index now pushes us into doing that. So again, good food for thought when it comes to why we no longer have, quote unquote, the gold standard of 90 millimeters of mercury pressure is the threshold for determining hypotension in a patient. All right, so let's go back to this article, the article that kind of got me going on the shock index a little over a year and a half ago now. All right, this is the article that was published in Trauma Surgery and Acute Care Open by Kierbach. And it piqued my curiosity twofold. A, because I spent a lot of time in the pre-hospital environment, and I love the pre-hospital environment. So that always piques my curiosity. Anything we can do to increase and do better trauma care in that environment is always very positive. And it then translated over again into the trauma center and how there were some correlations there. So let's look a little bit at the data. I'm not going to go into a big data dive here. I'm not going to bore you with statistics and crap like that. I really just want to show you the information that really piqued my curiosity. And not that one article will ever make anyone a believer in anything, but if there was one article that really pushed me down the road of being a believer, this is the article. So in this particular study, they took a look at about 544 patients that presented to a trauma center. And they looked at hypotension versus normotension for whether or not the patient ultimately had a significant injury. And here's the data that right off the bat just knocked me on my butt. Out of the 544 patients, only 82 were documented to have hypotension at any point in their pre-hospital or trauma emergency department length of stay. But guess what? 247, so not quite 50% of them had significant injuries. No, didn't freeze up. Just take a pause there. What? All right. 66% of the patients with significant injury never displayed hypotension. Nope, didn't freeze up again. All right. Of those that arrived in the emergency department, hypotension was not associated with the need for emergent operations or mortality. So having one episode or having even a little bit of continued hypotension didn't predict jack squat. All right. And the significance is that hypotension was just a poor predictor of serious injury. That was one good conclusion that they got. That wasn't even the prime op of the study, but they pulled that away from this data. And again, if you look at the chart in particular, you see the fact that they had a lot of normotensive patients that ended up having significant injury. And that's blew my mind. What else did they find? Well, they find that when they looked at the shock index in these same patients, that the shock index was statistically significant, all right, was much better a predictor for significant injury, the need for transfusion, whether it would be 1 unit of whole blood, maybe it would be 1 round of 1-to-1-to-1 component therapy, or mass transfusion, all right? But it was better at predicting it. It also was a better predictor of death in the emergency department. And last but not least, and certainly in trauma, we need to know this, it was also a better predictor of whether or not the patient may need operative intervention, okay? And this would have been either acute operative intervention directly from the trauma bay, or maybe admit to ICU and then have to go back to the operating room. Again, the numbers there are darting, and I don't get really caught up in the numbers, and if you're not into statistics, that's okay. But you look at the p-values, which again is kind of talks about the clinical significance of these findings. All the p-values are less than 0.05, which really tells you these are not things that are happening just by circumstance. There's something going on there that we need to pay attention to. Furthermore, and these are little charts that show things, but if you just look at the arc in the chart, the little red arc here, it shows for significant injury, certainly this was a better predictor. Now, this didn't rise to what is considered to be clinically significant, but it was significant nonetheless. But if you look over here, the need for transfusion, now let's translate that. Need for transfusion in a trauma patient means what? They're hemorrhaging. And what do we know is the number one preventable cause of death in a trauma patient? Yes, hemorrhage. So anything that's going to allow us to be able to predict and intervene for hemorrhage is a good thing. And this was an ardent, I mean, the p-value, you can't get a p-value any lower than that. So that really tells you that we are onto something here, and it's something we need to take note of. So that's my crash course in statistics for you today. So when I looked at this literature and when I looked at other literature, what were some of the conclusions that I kind of came up with? Well, first of all, hypotension alone is not a predictable indicator of 4 main variables that we're looking at in our trauma patients. A, significant injury. B, the need for transfusion, which translates into the patient's hemorrhaging, right? The need for operative intervention for those acute hemorrhagic injuries, or mortality. The patient's going to die on us, right? So if it's not, why the heck are we using it? Why the heck are you using it? Why the heck have I been using it for the last 35 years before last year when I started to change my approach, okay? They also found, and this is again through multiple articles that are listed at the bottom of the slide, that an elevated shock index greater than 1 is a better predictor of all 4 of those items, okay? And that's even in patients that are normotensive, because you're not just looking at a systolic blood pressure, you're looking at the heart rate and the systolic blood pressure. And then last but not least, that there should never be a single physiologic parameter that we define anything by. All right. Because guess what? It's going to get us into trouble. We're going to go down the road of over treating a patient. The trauma surgeons are going to get into the road of taking patients up to the operating room, opening them up, and they find nothing. And they do that a lot. We know that historically, a systolic blood pressure of less than 90 has been used in isolation, and there's no good clinical findings. There's no good evidence to support it. It's a fairly arbitrarily decided number, and it's time to maybe throw that number out if you are so inclined. All right. And there are a lot of confounding variables, even when using the shock index when it comes to the patients that we see. So even if we do use the shock index, or even if we're keeping an eye on heart rate and blood pressure and respiratory rate and end tidal CO2 and all of those parameters that we should be watching now in our trauma patients, we have to bear in mind that there are patients that come in with comorbidities that are going to impact the physiologic response to injury. There's age, which has a very big physiologic variance, and there's polypharmacy, right? Over 65, you're probably on the average of 5 medications. The chances are high that at least one of them will impact both blood pressure and heart rate. So those things have to be taken into account in addition to looking at the numbers. And I think we all know about that. And then certainly, and this really was the big thing, because when the American College of Surgeons did their revisions of these trauma triage guidelines, they really looked at an evidence-based approach, and they're integrating shock index now into these guidelines. Really catapults the shock index far as to becoming a norm with regards to our using it in our assessment parameters. Okay. So, and we see these adaptive uses that have come on the market, and this is really only over the last year, year and a half. Again, I've talked about these trauma field guidelines. There's now shock index dosing for RSI. So for those of us that are working, particularly in the trauma setting, we know that we try not to intubate patients that are hypotensive because they're not optimized. And if we intubate and we RSI a patient who's hypotensive, they're going to die on us, right? So now we've actually developed shock index dosing for RSI, smaller medications, push dose pressors when we're doing intubation in a patient that we have to intubate, but is maybe hemorrhaging and we can't wait any longer to control their airway, right? There is now the shock index that has been integrated into trauma team activation protocols. At St. Joe's, we have shock index as one of our indicators now in our trauma team activation criteria, based largely not only on the literature and my pushing it over the last year, but also on the field triage criteria. And we're seeing more and more on talks that I go to and listen to that the term shock index is now becoming very, very commonplace in these talks. So if you don't know what it is and you're not using it, then you're going to be lost when you're watching some of these talks, whether they're live or online or even in the literature. And fortunately, although certainly not, and I hope at the end of tonight, we certainly will have about 25 of you that are now amongst the trauma clinicians that are out there that are using the shock index in your practice, that you should be using it. You should be integrating it tomorrow, and you should be reading up on it. It is an extremely important parameter. Is it going to be an earth-shattering revolution? Yeah, probably not, but maybe so. Who knows? If you can pick up on just one additional patient in the course of your weekly care of trauma patients, that maybe the shock index has now pushed you into thinking something you otherwise wouldn't have thought, then boom, there's nothing wrong with that, right? Once again, this is a list of the references that I've gone through. There are additional references that have come out. I've got a stack of about 5 or 6 papers that have come out since the summer, the early summer, that are still talking about the shock index. Another one on the pediatric shock index, things like that. So there's some good literature that is coming out, and there's some relatively decent systematic meta-analysis studies, which are almost as good as randomized controlled trials, but not quite, when it comes to looking at, again, the shock index and its applicability in the trauma environment. So that is that. That is the references. So what I'll ask you guys now, if you want, you don't have to, but you guys, if anyone has a question, pull yourself off mute. If you want to raise your hand, I can do that. Bring yourself off on camera if you want to talk, or if you have any questions, this would be a great time that we can entertain any questions you might have. If you want to put them in the chat too, I can even look at the chat at this point in time. If you don't have any questions, that's great. It means either A, you all were sleeping, or that everything is great and that tomorrow you're going to start utilizing the shock index in your practice. Excellent. Yeah, Susanna, that's great. Definitely, I would advise you bringing it up. If you go back to your trauma team and you see like a lot of like deer in the headlight when you mention shock index, then there's a fair amount of education that you're going to have to do, right? I think it's really important that if we're not using this, you're there. I think you're going to be surprised that if you go back to, if you're in a trauma center and you go back within your trauma programs and you talk to your people, they've heard of it. They just maybe haven't utilized it or don't understand how important it is to utilize it, right? Anybody have any questions? And it's okay if you don't. I mean, if it's really was that great a talk and you have no questions, then I'm happy.
I have a question.
Ask away.
Hi, so my question is, are you using just the initial set of vital signs to measure this shock index, or is it your trending vital signs for it?
Yeah, absolutely. With everything in vital signs, it's all about the trending. So certainly from an initial screen, you get a set of vitals either from the pre-hospital providers or when they come into triage, then boom, you're like, wow, light bulb goes off, but absolutely trend it. And you're going to trend it for a couple of reasons. A, if you're a believer in the shock index, you're going to treat the patient based on the shock index. And what you're going to see when you start giving them blood, not IV fluids, but blood or blood products, that guess what happens to that shock index? It comes down. And there's a lot of data in the pre-hospital setting now, particularly in places like Florida and Texas, where they're using pre-hospital blood, that a patient on the scene of a gunshot wound may have a shock index of 1.7, which is outrageous. And they get a unit of whole blood, and their shock index is trended down to 1 or less than 1 by the time they get to the trauma center. That is success. There's some good survivability there. What we haven't seen and what hasn't been done yet is looking at 30-day survival for patients that this trends out on. There are some studies right now that are being done. The litmus test out there is, do patients survive at 30 days with a greater percentage for that have gone down the road of shock index than those that haven't? So the verdict is out on that. My thoughts are absolutely it's going to, because anytime you can stop shock in its tracks earlier, what does that mean? They don't get into the fatal triad or the fatal diamond, if you want to call it that now, and you can stop them from going down that slippery slope. Make sense?
Yes, thank you.
Absolutely. All right. Any other questions? And again, I'll give you my, well, there's my email address up there. So if you have any questions after the fact, absolutely reach out. If you, I'll give you a QR code here in a second, that'll allow you to click out and do the evaluation. I'm going to put it up here in just a second, and then I'm going to also run over and try to get the link for this as well. So there is that. So while I've got that up there for just a second, I am going to go in and grab the URL for this so I can put it in the chat box for you guys. I may not be able to, because this may not let me do it. Yeah, it's not letting me. So just do me a favor. Sorry about that. I usually have this copied and pasted and ready to go. I'm going to go back the slide. If you haven't already done so, just quickly copy my email address down. If you don't have the ability to QR code and get into the evaluation tonight, just do me a favor, send me a quick email and I will send you the link so that you can just click on the link and get into the evaluation. And again, I'd like for you guys to do the evaluation, even if you don't want to claim for your credit, because I'd like some feedback from you. And if you have the ability to ask any questions, please do so as part of that process. Typically, what I will do with this is when you go on and you do the survey, some of you are already on my list. If this is the first time that you're participating in topics, which for a lot of you this is, at the very bottom, if you are interested in being put on my email list for future iterations of this particular series, then that'll be great. I'll put you on my email list. So make sure you let me know that in the bottom of your evaluation. And then what I'll also do is what I typically will do is once I render this and I put it up on the YouTube channel, I will give everybody about a week to go up and watch it online and claim CE credit for it as well. So if you've got some colleagues, or for Susanna, for Kenzie, if you go back to your individual teams over the next day or so and say, hey, this guy may be onto something. Once I render this and get it up there, they can go and watch it and either say he's full of shit or hey, he's onto something. And they can even claim some credit for it. At least the nurses can. The docs are on their own. Again, the next session of Topics in Trauma Nursing is going to be on December 13th at 8 p.m. Ballistic Basics, Understanding the Injury Potential of Gunshot Wounds. So who isn't interested in knowing what a bullet does when it leaves a gun and it enters a person, our patient? So if you're interested and you want to join in for that, I certainly open an invitation for you to do so. And then last but not least, again, there's my email address. If you have any questions or comments, please reach out to me. I appreciate all of your time tonight. This has been a great group and had some good questions. And even for those of you that were quiet, that's cool. I hope that you found tonight's talk enjoyable, maybe earth-shattering, right? Maybe you'll go back and use it in your practice. And then for our future colleagues out there at William Patterson, thanks for joining in tonight. If you all have any questions, you can certainly reach out to me. But emergency nursing is phenomenal. Trauma nursing is phenomenal. And so don't think you can't be a new grad in this environment. We certainly need the nurses in the emergency departments now. So that being said, thank you all for your time tonight. And we will see you on the next incarnation of Topics in Trauma. All right, take care.